Hello, everybody. Welcome to COXO Fee Public Webinar. This is Carol from COXO Self Department. Nice to see you again. Last time, many friends for Dr. Sanet have a wonderful speech, and I believe many dentists have get new knowledge from last webinar. And COXO is continue to make free public webinar. Please continue to follow our page. And today we will invite Dr. Shalu from India to do webinar, their presentation, and his topic is tip and trick to manage endodontic challenge. Before the webinar, I want to show you how to get the certificate because each COXO Fee public webinar we will award the certificate for dentist friends. So now I will introduce how to get the certificate. First step, you need to follow our page and like as your page. Step 2, you need to leave the comment or question below the live video. At the end of the live, we will share the phone link on the comment, and you can check the link and fill up the link and apply the certificate. About 3 steps down, in 5 days later, you will receive PDF form in your mail. And please be sure to think a very important thing. The first thing is the application form is only available for 5 hours. So please, if you want to get the certificate, please fill out it as soon as possible. And the second is the application form cannot be modified. So please be sure your left information is correct. And here is our certificate. And it also have our president signature and our stamp for technology. Okay. Okay, this COXO Fee webinar is invite the professional from India. So I want to introduce our local agent, Saramango company, to our Indian market. And if the dentist want to buy any product of COXO product, you can connect with our local agent. Now I will say hello to our agent. Hello, Mr. Andy.
Hello.
Hello,
Yes.
Andy. Okay.
Hello, Carol.
And welcome to our 5 fee public webinar. First, I want to give you some time to make the presentation about your company in Indian. So now it's for your time to introduce your company.
Okay. Thank you, Carol. Sarvamangal and COXO, we welcome all the eminent dentists. Sarvamangal Group is consisting of many companies with Sarvamangal Healthcare Private Limited, Sarvamangal Enterprises, Acumen Services, Sarvamangal Healthcare Innovations, and Dr. B.N. Kulkarni Charitable Trust. So we are very proactive, innovative, entrepreneurial, and with integrity and dignity. We work with a very proper organization structure. We have board of directors, then managing director and CEO, and then we have various departments to take care of all the needs. Our vision is to build a stronger dental community prepared for all future challenges, to provide dental practitioners with the equipment that keeps them ahead, optimizing their treatment workflow, creating a platform for modern techniques and patient communication. And Sarvamangal will definitely constantly work to meet and exceed the expectations of our customers. Sarvamangal means effective solutions for dental practices and clinics, and our goal is to find new ways of offering something better than the best and providing customers with the ultimate smile that lasts longer. Sarvamangal and COXO together, we want to become a respectable dental alliance, and we had been together for long period. So we are there among Sarva COXO's India representation for sales and service. COXO started in 2003 and Sarvamangal from 2000, and from 2007 our association is growing, and we provide sales of COXO's world-class equipment with backup for the best service, ensuring dentists to have a peace of mind while using COXO equipment. So there are various products we deal with, mainly the nitrophiles. Then we also have endomotors of various endomotors. We have curing lights. We have apex locators, obturation system, electric motor, alginate mixer and caries detector, and physio dispenser. These are the major products. And we are having, for this special webinar, we are having very, very good offers. Please do contact. The numbers are written there. And these are our all the details. Thank you. Over to you, Carol.
Thank you
Hello, Carol.
for your presentation about your company. And hello, dentists. You know they have a very good offer for this fee public by banner. If you want to buy anything, please connect our local agent. And also there have the information on our common. Common have our India agent company information. If you want to buy it, please take this chance because it have a big offers. Okay, now I want to invite Dr. Shanu to this presentation to share his presentation. Huh? Hello, Dr. Shanu. Hello. Hello. 你忍录一个试一下，再 add 忍录一个。Hello, Dr. Shanu. 他退出去了。Okay. Maybe there is some international problem with Dr. Shanu. He is not on the line now, so I want to discuss with our agent in India because we cooperation with Saramango is more than 10 years, right, Mr. Andy?
More than 15 years now.
More than 15 years now, and we have very good cooperation. And Andy Saramango company have provides very good after sales service. And sorry, and if you buy from our local agent, they will support the after sales service. So we doesn't sell any product online. So if you want to buy product in Indian, please connect with our local agent, and he will support very good service after sales service. Also for the sales service is very good because I also know a lot of ND customers such as Dr. Manda, Dr. Ashish, and they are cooperation with Mr. Andy for a long time. All of them, they are say Andy is nice person, and also he is very good company.
Thank you. Thank you, Carol. All the people who are listening to us from India, joined us for India, please do have my numbers. And we are there to service all the COXO products now or the old one and the new one. Whatever we are selling, it will be available for you at the proper prices. Yeah. So
Okay. Yes, yes. So if the Dr. Shanu, Dr. Shanu is
I'm
connect.
here.
Hello,
hey,
Dr. Shanu.
welcome,
Okay.
Dr. Shalu.
Thank you.
Okay, now we give the time for Dr. Shanu to do the presentation, and his topic is tip and trip to manage endodontic challenge. And also, Indian dentist, if you want to buy any product, don't miss this chance. It's big promotion. Connect with Sour Mango and give you big discount. Okay, now we give time to Dr. Shanu.
Carol, I think I'm audible and visible, right?
It's your
My
time.
screen is visible, Carol.
Yes.
Okay, so a very good afternoon to one and all present here for this weekday special webinar on a Thursday afternoon. I know it is tough for everyone to leave their practices and just join in this webinar, but I will make sure to give certain tips and tricks to manage certain endodontic challenges. As we know, our field is really interesting and is filled with a lot of challenges, starting from reading or diagnosing a case to just filling it post-op, doing a post-op restoration. Each and every step in itself has a lot of challenge. So today in my presentation, I have taken, though we have a time constraint, so I've taken certain challenges which I feel are we encounter day to day, and they are really tricky to manage. And once we start managing them routinely, our work and our workflow, it becomes very smooth and easy. So I welcome you all again in this webinar. This is one of my favorite quotes, so I would start my presentation with this: that being challenged in life is inevitable, being defeated is optional. Obviously, be it life or endodontics, no one can guarantee that we won't be getting challenged. Like now, today, after my post graduation, it's been 10 years, but what I still feel that each and every case that I enter inside the pulp chamber is a new challenge, and I take each and every case as a new challenge, and that drives, that's the uniqueness of our field, our branch, endodontics, because we have something new to treat in each and every case, and we are curious to encounter new things, to manage them well, and to give good results to our patients. So challenges, if there is no challenge, I feel the life or the work is very monotonous. But if we always ready to accept these challenges and to overcome or to know how to manage them, it is always good for us and for our patient as well, and that's for our practice. So the first challenge, be it any general dentist or an endodontist, the biggest nightmare for everyone in every case is a hot tooth. A hot tooth is not hot tooth because it has a higher degree of temperature. A hot tooth is a hot tooth because the patient represents you in a condition where pulpal tissue is in higher degree of inflammation, acute inflammation, that can be in a position when a patient comes to you with a symptomatic apical periodontitis or a symptomatic irreversible pulpitis, which was previously used to call acute pulpitis and acute apical periodontitis. You see, the success rate of inferior alveolar nerve block in irreversible pulpitis is just 19 to 56%, so almost 50%. And then we start, sometimes we feel low, and I get to get certain calls from my juniors or students said that it's so embarrassing in front of patient that our anesthesia is not working, our RCT is so painful for the patient, so how should we manage it? I feel whatever skills we have, whatever instruments we have, and whatever infrastructure we are carrying in our practice, that always comes secondary. The first experience of the patient with your work is what he will or she will carry for the lifetime, and that will send you many more patients, and that's how you grow in your practice. So to give good results, be it a radiographically or anyways, if the results are so satisfactory for you, but the patient, if he or she felt pain in her first visit and she encountered pain during root canal treatment, that would be the worst thing that she would carry with her, because that will remain with her in her psychology for a longer period of time, whatever efforts you are putting in afterwards. So how can we manage this? So this is a nice article by Dr. Abbott, that various strategies of pain-free root canal treatment. We all know we have a list of local anesthesia, short acting, long acting. So most commonly we usually use 2% lignocaine in our practice, but it is in various studies they have seen that mepivacaine and bupivacaine, these local anesthesia, when they are infiltrated locally, buccal and lingual, they give a very effective and long-term anesthesia for patient with acute irreversible pulpitis or acute apical periodontitis. Because up now there are certain studies, the recent meta-analysis of studies has shown that there was a little discrepancy in the studies in the past. The studies which were saying that lignocaine is less effective than mepivacaine and bupivacaine, they might have taken the samples in their study where the pulp tissue was not inflamed, rather it was healthy. So they tried these anesthetic agents in different studies. Certain studies they actually used it only in cases of acute pulpitis or periodontitis. Those are the studies which can give you right results for your clinical practice, because you encounter hot tooth not in a healthy pulp. Anesthetizing a healthy pulp is extremely easy. You see, you do extraction, you hardly sometimes you feel these problems, but when you enter inside the pulp tissue, that is the time when your patient start jumping on your dental chair. So obviously a local anesthetic agent has its own value, but why does it happen? Because there is always, whenever there is acute inflammation, there will be a lot of prostaglandin secretion due to the neutrophils and neuropeptide secretions. So these prostaglandins, they sensitize the neuroreceptors in the pulpal tissue, and then it becomes for the local anesthetic to penetrate and to reach to the sites and to anesthetize the pulp effectively. As you give local anesthesia, you would always ask patient, do you have lip numbness? Do you have this? And then patient will keep saying, yes, I do have lip numbness. I do have tongue numbness. But the moment you start your motor or aorta and you enter inside the dentine and you go deep into the dentine, the patient starts jumping. Why does it happen? Because the fibers, the C fibers or the A delta fibers, they are tricky to anesthetize in inflamed pulp. So it is important to just be reassured that your anesthesia is effective. How can we do that? We can do that after giving a local anesthesia, rather than just asking for symptoms from the patient. It is good to check the signs. What are the signs? You can do cold testing or electric pulp testing on the tooth. Now you can ask, will the same tooth will give you an accurate response? Like if the tooth is anesthetized, the tooth you are going to treat, if it gives you negative response, it means the tooth is fully anesthetized. Then again, there are studies which shows, because the pulp chamber or the coronal pulp might have anesthetized, but the apical inflamed area or the pulp tissue would be tricky to anesthetize. So the best way to check this is to check on the healthy tissue, the healthy tooth adjacent to your tooth on which you are going to work. So these are few reasons why you encounter hot tooth, and these are few information that this interesting article gave you. They say the first and foremost thing is to overcome patient's anxiety. Patient anxiety is being the most important reason of getting a hot tooth, because most of the time that when patient enters to a dental office, howsoever beautiful you have made it, but still the scare or the fear of a dental treatment is always there. So the way your dental staff and the doctor or the operator behave with the patient, console, and also the confidence of the doctor or the operator and the staff members, the all these impact factors on the patient, they help him in controlling his anxiety, because he would always understand they are giving or they are doing their best to give me a painless treatment. So the behavior of the entire staff and the operator in front of the patient, it actually matters. Once your patient is in your control emotionally, it is very easy to undergo the treatment flawlessly, smoothly, because then he or she will cooperate you well. Then what is the next point? Always be honest. I always feel, be it a very apprehensive patient or a normal patient, or be it you on dental chair, if you just prick or inject without giving a prior information, a detailed information, I would say, it is always a jerk effect for the patient. So if suppose you want to give a local anesthesia, always use fine needles. You cannot use large bone needles for local anesthesia. So you should use fine needles. Before giving anesthesia, anesthetize the area with topical anesthetic agents. That too, you need to explain to the patient that at this particular site, now once it is numb, I would inject local anesthesia. And suppose you need to give intrapulpal anesthesia, which I'll be talking about, which is like a really painful thing. If you are a patient on dental chair, you would imagine that it is not so easy for a patient to just take an intrapulpal anesthesia. So if you counsel your patient well in advance, he or she will definitely help you and support you and cooperate you well for taking that even intrapulpal anesthesia. So what is the trick of giving an intrapulpal anesthesia after your local anesthesia, your supplemental anesthesia is not working? So the trick I use mostly is, even after giving my local anesthesia, I would give a supplemental intraligamentary anesthesia. That is always there in cases of acute pulpitis or acute apical peritonitis. It is really helpful. So after giving intraligamentary anesthesia, if I still feel that pulp tissue is still not completely anesthetized, the most important and first thing is to give a lot of time to your patient. The biggest mistake that everyone does in we do in our practice is we are lacking in time. We have limited time constraint, and we have to perform a lot of procedures, access opening, shaping, cleaning, and we want to do everything in single sitting or maximum in 2 sitting. So we don't give appropriate time which a pulp tissue or inflamed pulp tissue wants to get fully anesthetized. So giving at least 10 to 15 minutes is highly recommended. Sometimes even 20 minutes is recommended. And if you jump before that, it becomes a problem, because you will do all the procedure in pain, and then afterwards your anesthesia is start working. So there is no point. So once you want to give, you have given your local anesthesia, then your supplemental anesthesia. When it comes to pulpal anesthesia, use a very fine needle. Explain your patient well the situation, and then give it gently. The patient will definitely accept it. And it is easy for you and for the patient to, work on a asymptomatic tooth later on. Also, it is important to ensure that once you complete your procedure, it is very important, once your patient is about to leave your operatory, he or she should not be in pain. So if you feel your procedure took longer period of time, you can give in between another shot of anesthesia, or if you feel after your complete shaping and cleaning, or suppose after obturation the patient is in terrible pain, it is wise to give another shot of anesthesia before patient leaves your operatory. All these things will definitely help in your practice building and trust building over the patient. And as a human, it is quite expected from a doctor. So pain during injection has no significant effect on success rate. Initially, certain studies were, they put a question mark that if the tooth is not getting fully anesthetized, will it affect the outcome of the treatment? So the studies have proved that it doesn't happen. And also there is no significant difference on the efficacy of anesthesia between, depending upon the bevel side of the needle. When infiltration and injection is used, make sure that when you are giving an infiltration, especially in maxillary, premolar, molar, or interior region, or supplemental injection, suppose buccal or lingual infiltration, make sure your needle should cross the apices. The biggest mistake that we do, we don't see if the canine is of what length. You just imagine or see it on pre-operative radiograph. And if you are giving local infiltration, that too below the level of apices, it won't be that effective, or it won't be much effective. So if a patient has a history of difficulty in obtaining anesthesia, most of the patient, they will themselves give you a history like, doc, that I don't get anesthesia easily. I had a terrible pain in my last treatment procedure. So you need to be ready with all these things prior, that you should be prepared with your supplemental anesthesia technique, your intrapulpal anesthesia technique, and obviously the major thing is patient counseling. Emotional counseling, for me, it's like it works the best out of all other things. So if the practitioner assumes that the root canal treatment may take longer, it is better to give anesthesia in between. So these are the ways how we can give supplemental anesthesia. It can be intraosseous. Intraosseous anesthesia can be given with the special devices like Cshaped. Then we can give intraligamentary anesthesia and intrapulpal anesthesia. The question comes, the effectiveness of intraligamentary anesthesia is really good. So where should we give intraligamentary anesthesia? Periodontal ligamentous space is present between the root and the socket or the wall of the bone where your tooth is embedded. So you need to give periodontal ligament anesthesia. You would take your fine gauge needle. You have special devices like Ligaject also, and you can give with your fine tip needles also. But you have to be very precise that your tip should enter into this space, particularly in between the root and the bony socket. Most of the time people think that they are giving intraligamentary anesthesia while they are just giving a gingival anesthesia. So that won't be effective. To give an intraligamentary anesthesia, both mesial and distal to the affected tooth is extremely effective. So this is how, these are the things which can obviously help in getting a profound anesthesia. And once, already we have lots of challenges that we will be talking about. So once your patient is not, cooperative or is in pain, you cannot focus on the things which are inside the pulp chamber. So it is the first and foremost requirement to, before managing any other challenge, to overcome or overcome this hot tooth challenge before performing any other further procedure. Now, most of the time, the second challenge everyone talks about is while treating a maxillary molar, they don't find MB2. The MB2 dilemma is a much talk about dilemma, though now with the in last 5-7 years we have seen that now people are very much convinced that yes, MB2 do exist. Before that it was really a task that people were thinking, yes, it is an extra canal, or it is like something, if one was getting MB2, it wow. Nowadays if you don't get a MB2, it's a wow case for me. So you see here the first case of MB2 canal, it is not recent. Hess in 1917, he used a vulcanized rubber and, with pressure, he put inside the pulp chamber and decalcified the section of the tooth and saw mesiobuccal MB2 canal. That to a full length canal. So the MB2 canal is not a new thing. It was already mentioned way back in 1917. Now the latest studies, keep on coming with the advent of newer three-dimensional technology like CBCT and microscope and other things. So now you see the prevalence is almost like the study in 1999 by Stropko said it is 93% present. But the more sensible study, in my opinion, would be a study which gives you the results depending upon the region or the areas in the world. You see a lot of changes as per the demographics. So you see in India, it is almost like 64.8%, while in certain areas it is like 97%. So suppose on social media, one of the speaker or one of the mentor is saying it is always present, or it is 90, more than 90% time it is present. So he is right or she is right. But if a person is saying it is not always present, is also right, because it is not always present. So everything is like, how can you deal with it? Do you have a preconceived notion about is it really present or it's not present? In my opinion, there should be a sensible approach towards any missed canal or towards anatomy of pulp chamber or the complex anatomy of pulp tissue. If we talk about, the most sensible approach is to always expect extra. That is how I do. I would always expect extra, because if I don't expect, I would not try to explore. If I'm okay with three canals in maxillary molar, if I'm okay with 2 canals in mandibular second molar, or if I'm okay with 3 canals in mandibular first molar, that would be a problem. And that's why we see a lot of retreatment cases coming to us, because somewhere certain people have they have restricted themselves. Also, at the same time, don't be so fussy about it. You should be knowing that it may present and the chances or prevalence is really high, and you need to give your best to find it out. But if you don't find it out, you need to either believe in 3-dimensional radiography to just confirm your diagnosis. So coming to MB2, the best principle were given obviously by Ranko and Kressner in way back 2004, the anatomy of pulp chamber flow. How can we come to know that how many canals a tooth has? This tooth. So if you see this picture is a much enlarged picture under magnification. But if you ask me, it was a retreatment case. And if I see this tooth without magnification under your good illumination and a good hand mirror or the mouth mirror, what I would see, I won't be able to, appreciate anything. The tooth will look like perfectly, clean and everything is fine. And this is just dentine present. The chamber looks to be calcified. It's a retreatment case. But once you see it under magnification and you believe in Kressner and Renkow principle, that the floor of the pulp chamber cannot be so wide. It has to have a darker color hue. So you will just then see and then will remove all that extra thing that was just a composite or mixed of, calcification and the previous restoration. And once I remove, now I can clearly see if this has extra palatal canal or if it has MB2. So the point here I want to show is one can always find canal even without removing all the extra content of the pulp chamber, but that is not the right way. If you are encountering a retreatment case and if you don't remove these things, you have a lot of dead and necrotic tissue below it. Now this is an interesting study which says, where does it lie? Where is MB2? So the study says that most of the time what we are trying to find out, we do our access quite mesial. If you see the center diagram in which they have demarcated, with dots, they have demarcated a mesiobuccal, distrobuccal and palatal canals. How they did, they just sectioned the tooth and they just, recreated the image of the pulp chamber orifice level over the occlusal anatomy. So this is how they saw that the canals were in a healthy, young patient, the canals are always in the center. And what we are most of the time doing mistake is we are trying to find them, or we are cutting more of the marginal ridge area, especially towards the mesial side. So the mesiobuccal canal, if you see, it is present between the buccal groove or the central groove and between the mesiobuccal cusp tip. And the distrobuccal is always slightly in line with either buccal groove or slightly distal to the buccal groove or the central groove. And it is slightly more palatal. So it is not just a flat straight line, mesiobuccal and distrobuccal. The mesiobuccal is slightly buccal and distrobuccal is slightly palatal. And palatal canal, it is almost in the center, in a line with the central groove. And this is how one can always save a lot of tooth structure. But what happens in our practice, we usually don't get such intact teeth until unless the patient has, some kind of class 5 abrasion defect or cervical caries or some special issues like, Kray's line or fracture line. The fine fracture line leads to the apical inflammation. Most of the time we encounter a tooth with carious exposure. So in that case, if the caries is mesial, one has to approach after removing the entire caries. So I always believe in caries directed approach, which is more effective. Now, if you see the articles or the studies already say the effectiveness of microscope in, finding out MB2 canals. No one can doubt about it. You see the prevalence of MB2 canals, it is increasing day by day. Why? Because of we have now microscope with us, the best quality of microscopes, and we do have 3-dimensional technology by means of CBCT. So there are very less chances that we would, miss them if we are aware. So you see, when a person is trying to find out MB2 without any means of magnification, the chances are just 17.2%. And with the loops, it increases to 62.5%, and with the magnification, it's to 71.1%, which is like huge, from 17 to 71% without magnification to magnification. So my point here is, I want to explain the need of seeing and believing what we need to see and then to find out, because it is all hypothetical otherwise. If you don't see inside, if you are not able to appreciate by yourself, it is difficult. So once you have good magnification and good access, you can even do even in a caries directed access opening, it can be as minimally invasive as possible. But at the same time, if a person is new to the field or a new clinician, my advice would always be not to be very conservative, because you might save a little bit of dentinal tissue, I agree. But if you don't have good hang of and a good experience of doing lots and lots of maxillary molar root canal treatment, the chances of you missing mesiobuccal MB2 canal, or sometimes even MB3, MB4 or DB2 canals are really high. So the wiser way, if you have good experience and you are sure that now my pulp chamber has restricted and I can see the dentine all around and I don't need to extend anymore, is good. If you feel that you are not confident enough, it is wise to make a good clear access and then to find out the canals. That is more important. So after CBCT, the chances of getting MB2 canals are even high if you see this study. So when should I use a CBCT? Shall I use it in all the case to find out MB2? I can, but I won't. Even if I have my in-house CBCT, I won't. Why? Because I want to believe in my vision, in my, my own skills of finding a canal. I won't believe or passively believe in a CBCT machine, because that can give me information. It is good, but for patient's sake, I don't want to expose him just for the sake of finding an MB2 canal. But cases like this, when you have your doctor patient with you, one of your student or junior, and you do a root canal treatment, you are not able to find even MB2 in this case. So what would you do? Will you obturate it? No. So in this case, I would take a CBCT, and this what I would see, that coronally the canal was one. It was only one canal. But as we were going as we were going more apically, the canal was splitting into two. If you see this image, in this blue arrow is indicating there was a split quite below the CEJ. So the canal was there, and if you see the last image, the canal was having its own portal of exit, POE. It was separate, so the chances of failure in this case was obvious. If I don't rule out MB2 canal, if under magnification I'm not able to see, I cannot just say that it is not there. I have to be very sure, I have to confirm it with CBCT that if it is there and I'm missing it. So after I confirmed with CBCT, now I could see, and with the magnification, even with the minimally invasive access, I could do this. But doing a minimally invasive access and missing a canal is not at all recommended. Another case, where should you stop is another question. You have CBCT access nowadays, you have magnification, but when do you need to stop? If you are stopping at this stage after ruining entire dentinal structure and then you are sending your patient for CBCT, I feel it is so bad, because now the entire strength of the tooth has already gone. So this patient comes to me with a lot of pain, acute pain, after somebody was trying to find out hopefully MB2, because the patient was in terrible pain for last 2 to 3 visits and was symptomatic. So once I straightforward took the CBCT, because there was no margin of playing with the structure and always a calcified case. So once I saw that MB2 canal was there, now it is my duty to find it out without removing any further structure. So I just built the entire pre-endo build-up, all the structure which was lost with the composite material, and you see the chamber was so badly calcified. But now, since I had the clear assurance from CBCT that MB2 is there, I could even take the measurement how far it is present. And if you see MB2 canal, it is not always in straight line to mesiobuccal canal. If you draw a line from mesiobuccal canal to palatal canal, you would see MB2 canal is more mesial to a line. So don't waste your time and don't remove much of your dentine of the patient, but in searching MB2 canal, in line with mesiobuccal canal. It is more towards the mesial side, towards the premolar side. And please always use ultrasonic tips or ultrasonic instruments, no burr or cutting instruments, because you would remove a lot of structure here. So for all those who feel that we are performing endodontics for past 20-25 years and we usually don't find MB2 canal, so will it matter? So the study 5 years follow-up showed that yes, especially in retreatment cases, the chances of getting MB2 canals were almost 66%. More than 58% was in initial treatment. So we cannot just play with the with the fact that I have more experience, and since I don't see many patients with the failure, you should always assume that might be your patients are going to some other better dentist after failure. They might not be coming back to you after pain or after failure of the treatment, because that's how a specialist or other people, they get more patients from the retreatment cases. So cases like this, when you have separate MB2 wide canals, you cannot just afford to leave them. It is your duty to find them, and the principle is very clear. First and foremost is magnification. You need to incorporate magnification, and under magnification, you need to know where to search for MB2. Is it present just below the mesiobuccal canal? Where is it present? So I won't like to give any distance between MB and MB2, because in my practice, I don't ever see a fixed amount of 0.51, 1.52 millimeter. It is not fixed. Sometimes you see the cases when you have a single orifice and both MB and MB2 canals are, they both are emerging from the same orifices. So the more logical approach is to remain minimally invasive by means of using ultrasonic tips to see well under rubber dam isolation and microscope, because then only you would be able to appreciate the chamber well. If you are seeing everything without rubber dam and without microscope, it won't be so clear. So finding is not difficult. The way or the path that we are taking to find a canal determines how difficult or how easy it is. So if today one says it is so easy and the other person says it is so difficult, I find it so difficult, the difference would be only in approach of finding it. Other most commonly missed canal and the most commonly encountered retreatment cases are mandibular molars, especially mandibular first molar, and we encounter middle mesial canal so frequent. It's almost 40 to 45% cases we've encounter middle mesial canal. Again, it all depends upon the area where you practice, but in Asian countries like ours, we do have a lot of prevalence of middle mesial canal. So how to find out what all types of middle mesials? See, in such cases like this, when you have a lot of radiolucency, how can you afford to miss a middle mesial canal? You need to find out, you need to clean the system, and then only you can expect the results. If you are not finding out, it is of no use. So most commonly what we get in middle mesial canal is confluent canal. What is confluent canal? In confluent canal, the middle mesial canal is merging either with the mesiobuccal canal or with the mesiolingual canal. But does that mean we can just leave it by thinking that it is merging so it won't affect the outcome? No, we cannot. Because if suppose patient has vital pulp tissue which is inflamed, the symptoms might persist. The symptoms of sensitivity and the pain might persist. And if a patient or has necrotic pulp tissue, the chances of being a failure cases are really high, because you cannot leave bacteria and necrotic pulp tissue inside a full-fledged canal, even if it is not exiting through its own exit. So the prevalence is really high. It's almost 40%, and it is more commonly found in mandibular first and second molar. In young patients, it's even higher. So the point is how to rule out. The principle here again is the same. You need to have a good isolation. You need to see it under good magnification. Once you prepare, the first and foremost principle, be it MB2 or middle mesial, you cannot just, from your starting, you cannot just focus on these canals. These are canals which you would be able to appreciate well after preparing your main canals. So the first thing is you need to prepare your main canals, that is mesiobuccal, mesiolingual, or distal, or mesiobuccal, distrobuccal, or palatal canals. And once you prepare, you see you have a clean chamber. Now you have a clean chamber and you have well prepared orifices of these main canals. Now it becomes so easy to rule out if we have any extra canal. What is the best way? The best way is to take a sharp explorer and to run the explorer in between mesiobuccal and mesiolingual canal. And if you find any catch, the catch would indicate you that yes, the chances are high, and immediately you take your stiffer files. I won't recommend using very thin 8 number 6 number files, because they are very flexible. Most of the time they cannot negotiate such fine orifices. So you take a C pilot file or any stiff file, and then you try to just with watch winding try to negotiate it. Sometimes some people with experience, they directly start with the rotary file. That's also okay, but that comes with experience. So middle mesial canal finding, or be it any canal finding, is easy only if you follow a certain path. So this is how you get a completely separate middle mesial canal also, and sometimes you get a confluent canal. So see here also, just after complete shaping, sometimes one would find, or I would find, middle mesial canal just before my obturation, because now my chamber is completely clean after thorough hypochlorite and EDTA irrigation. Now I can appreciate the anatomy of the pulp chamber well. So even if it is a calcified chamber, I would be able to appreciate or catch if there is any catch present between mesiobuccal and mesiolingual canal, and then obviously you can clean and fill it. So it is easy if you have retreatment cases like this where you have ledges in suppose mesiobuccal or mesiolingual canal. But what does this X-ray indicate? The X-ray indicates that there is a pathology. So some of the canal is definitely reaching to the apices where the infection is, why the infection is increasing, and why the periapical pathology is increasing in size. Also in distal canal, you can say the distal side has radiolucency, which shows that there is a distal exit of the pulp canal space. So in such cases, it is important to understand that there might be the presence of middle mesial canal, and then you can always expect good results. Because Our root canal system is a system. It's a complex system. It is not a round shape or precisely shaped canal. You have fins, you have isthmuses, you have anastomosis, you have lateral canals, so many things. So one need to understand, can we clean them with our rotary instrument? We cannot. We can just shape the canals so that our irrigation will reach to these areas. And then we have devices like this, where we have such nice ultrasonic portable devices where you can just agitate and you can expect a really nice acoustic streaming effect and the nice cleaning effect of these machines inside the pulp canal space. And then once the tissue is the pulp tissue or the bacteria or the biofilm is removed, you can always expect a good filling inside. The another challenge I would like to talk about today is C-shaped canals. So we have various classification of C-shaped canals. There are Milton's classification, then Fenn, improved the classification depending upon the angle of the canals, if it is less than 60% or more than 60%. So I'm sharing these articles because if you want to go in depth, obviously you need to study in depth. So it is important to first understand what all types of C-shaped canal you can encounter, because C-shaped canals are the trickiest canals, and they have really high failure rates. And the failure, you can always imagine, is not because of your shaping. It is definitely because of poor cleaning, because in such widely flared canal, it is difficult to clean these areas. If you see these pictures, the C-shaped patterns, it can be a continuous, it can be semicolon, it can be discrete C1, C2, C3. But the baseline is the shaping is important only to take your irrigating solution inside. You cannot expect cleaning of these isthmuses area or these fin areas with the help of your rotary instruments. Another very important point I would like to add here is, in shaping these canal, we should always understand, since the canal, the root has a conical or the rectangular shape root, and then we have a wide C-shaped canal inside, our shaping, especially towards lingual side, should not be very aggressive. If you are shaping your mesial side of the C-shaped canal, and that to the lingual side of the canal with lots of higher tapered instrument or aggressive instruments, the chances of strip perforations are very high. So study says that you need to be very selective in where to shape and how much to shape, because if you shape aggressively, the chances of strip perforations are really high. So suppose you get cases like this. These are not simple C-shaped canals. From occlusal cavity, what you would see after reading the radiograph, I'm clear that this is a C-shaped canals. If I know the classification, I know it is a lower mandibular second molar. Chances are really high, and it is a C-shaped canals, maybe type 3 of your Fann's classification, radiographic classification. So shall I just expect a mesial and a distal canal? No, it is a C-shaped canal. It cannot just be a mesial or distal canal. So in such cases, when even your magnification won't help you much, because you have a taurodontism kind of pulp chamber, the canals are splitting way down almost in the middle and apical junction. So you need to take a CBCT. Here you would see a single round opening at the coronal area, then an incomplete C shape in middle, and then a complete C in apical area. So how can it help me? It can help me navigating what to find out. Now I have measurements. Now I have with CBCT know where exactly they are splitting. Now my magnification would help me to reach to these areas. This magnification will predictably help me. I could do this without CBCT also, but I was not really sure what I'm doing. Now predictably I can do this in a precise way without overcutting or without traumatizing the natural tooth structure. So it is unbelievable how powerful you can be when you have a clear vision. Obviously, cases like this, they show us the power of vision. And then you can, I feel these cases are almost impossible to do in a predictable way without magnification or without three-dimensional imaging. Then once you get this, it is easy to take a working length measurement with a PIX locator and shape it and clean it with good flexible file like SE Pro. So in this, now again, when it comes to a C-shaped canal, more than shaping, I would emphasize on cleaning. So ultrasonic activation is unbeatable. And now we have these portable devices, so it is even more interesting and easy for us to, clean them so easily. So the thin titanium tips, they can easily reach to the apical third area where we really want them to be effective, and the effectiveness is really good. So once you have shaped the canal, you put a lot of hypochlorite and then agitate it well with ultrasonic devices so that you can clean them well. After cleaning, in such cases, honestly, I would believe to take advantages of flow and sealability of bioceramic sealer, because these sealer would ensure me that even if in certain areas, because you see in such torodontist case or in deeper splits, it is really difficult to be very sure that your seal is good enough, because you cannot just seal it three-dimensionally. So these sealers, they have good flow and they have good sealing and they are very biocompatible. So these bioceramic sealer are helpful in such case to give such results. So I feel these cases are really challenging, but if we know and we have we have magnification, we have good technology, but at the same time technology would back us up only when we expect and we ourselves are curious enough to find out something more. Otherwise this case could be done only by preparing one mesial and distal canal, also by reading a preoperative radiograph. So it all depends what you see and what you want to give. This is a clear and nice example of a case which I was talking about, because suppose this radiograph you read and you read and you need to do root canal treatment for both mandibular molar, the second and third molar, and you are very clear that what kind of canal morphology you have. Just by seeing a radiograph, you are sure that yes, 7 has C-shaped canal. It is almost like a wide single canal. It appears to be like that. But the person or the operator like me is more curious to reach to this apical split of third molar. So what I would do, I would just try to scout this apical area with my fine stiff files, C plus files, and I would just keep working on it while my 7 is lying there. So I would just use a lot of shaping, irrigation in between, and somehow this is how I would get and achieve the apical split, and even I can see the 2 exit of the apical foramina in third molar. So I felt it was like completely good day for me, that I could just negotiate and clean it. But this is how this master cone came, and I filled it. So I was really happy for this 8. But once I see this X-ray, this is the most important thing, to read your radiograph not only before performing a procedure, that is the most important, but even after completing your obturation, because even if you miss your first train, there is always a chance that you can rectify. So here what I saw is I certainly missed something here, and I could now see that there was a radiolucency lying here. What I did, I immediately removed the coronal GP, and now I modified my axis in a way that I could see this canal, this mesial canal of 7. So in this also, I had magnification before itself. But since my mind or my eyes were prepared to see only one canal, my brain was tuned to it, I could not see even if it was there, because my axis itself was very restricted. I did not modify my axis to rule out if there was one extra canal. So this is how I caught it, and then just shaping and doing is so easy. So this is how you can just clean and fill, but the requirement is not just the technology. Requirement is your own mindset, and then comes the instruments and skill. So performing cases, endodontic challenging cases is not just one aspect. You see, in all my cases, why I'm showing lots and lots of cases is I cannot just show these things or tell these things by explaining studies and theory. It is so difficult because for me also, I just started encountering and seeing these cases after a lot of experience, maybe of failures or realizing them late, like in this case. Now comes one of the major challenge, which I feel is the real challenge in endodontics when you talk about morphology or anatomy. If you ask me, finding extra canal or shaping two mesiobuccal canal, MB3, MB4, or distrobuccal or 7 canal, it is good, but getting all the canals, anatomy on your served on your CEJ platter is really really helpful. It's so easy because at least under magnification you can see all the orifices. But what about the cases when you have your blind vision? Under magnification, what you are seeing is just one orifice, while even with magnification you cannot see if the split or the canal is splitting into middle or apical third area. So how can we be sure that this tooth has a split or this is not, because we are not taking CBCT for each and every case. So how can we do that? The best and the easiest thing to do in such cases is to read your radiograph properly. So if I read this radiograph properly, what I would see is in distal root, you see there is a fast break. What is pulp chamber or pulp canal, which is wide enough, and certainly in the apical third, you are not able to see anything. It is just blank as if it is calcified. It cannot be. The canal cannot be calcified in the apical area while it has good pulp tissue. So it is a very, very clear indication that yes, you have a split here. Another indication, you see this working length radiograph here, the second picture. This is the second step. If you miss the first step by some chance, you need to catch here. If you see that your working length files, if they are not in the center, if they are not exactly in the center of the lamina dura or the lamina dura of distal root, the mesial and distal lamina dura, meaning that the files are not exactly in the center of the root, it means you are missing something. So if suppose in this case, both of my files, though after reading my radiograph, I was trying to take my file into split, but it was not going. So in this case, I see this radiograph and I'm even more sure that yes, there is one split. Now I would just pre-curve my file. What file? It should be at least a 10 number file, obviously not more than that. And it is very good if you use a stiffer file like C file or C plus file, which have stiffer tips, because somehow you need to pre-bend it and you need to engage them in the split area. Once you engage them, then you keep on doing watch winding motion till you reach to the apex. So you can do this only with not a very larger file like 15 number file, also not with very flexible file like 6 or 8 number file. So the best file for negotiating these splits is having a good stiff 10 number file. So in this case, clearly I had middle mesial canal. That's not wonder, but the most important thing was having this distal split. So this is how the split was clean and filled. And if you talk about premolars by default, they have a split, or you call them two rooted, or you call them one rooted bifurcating, or you call them one root having bifurcation or trifurcation, or even 4 canals branching from the main canal. So premolars are the most once upon a time, people were talking about charging your root canal treatment depending upon their location of the tooth. So now if I talk about this concept, I feel this is totally a wrong concept, because if you talk about premolars, the amount and time I invest on premolar is almost equal to a maxillary molar or a mandibular 7, because I would expect definitely some special anatomy in premolars, because chances are really high. And this picture shows the importance of changing horizontal angulation of the X-ray. If you see the third X-ray, you would see just a clear-cut one canal. You won't see, there is no doubt about having a canal. So especially in premolars, it is definitely important to take a pre-op X-ray having different horizontal angulation, a mesial shift or distal shift. And if you miss by chance in a pre-operative radiograph, it is wise to take a working length or master cone X-ray with a shift, with an angulation shift. Especially in a retreatment case, in a premolar, you would always expect an extra canal like this, and it was a full-fledged long canal, so the failure was inevitable. So these are special cases, and how can we encounter them and how can we manage them? If you read this pre-operative radiograph, one can read it as calcified canal, mesial canal, one can read it as single mesial canal. After under magnification, I was not getting two canals. So what I would do, I would always expect extra canals. Since it is a mandibular second molar, I won't be expecting two canals, one mesial and one distal. It has to have at least two mesial canal. The chances of not getting it are there, but still the more chances are of getting two mesial canals. So I would always go with more chances. So what usually happens is, most of the time, the canal that you locate just after your initial preparation, the first canal that you locate is mostly the lingual one, the straighter one. So in this case also, the canal that I would easily get would be the mesiolingual canal. What I need to do is, I need to bend my file, or I need to project my file in a way buccally, so that I can negotiate the mesiobuccal canal from the same orifices. So how can we do this? We can do this with pre-curving our file of a small number file, and this is how we can just negotiate this split. And then we have fantastic flexible files like this. So these SC profiles, they have such nice flexibility. You can even pre-curve them. I just want to add one point here. After pre-curving any rotary file, you cannot just switch on your endomotor like that. Otherwise, you will see a fan running in your endomotor. That makes you crazy. So what is the ideal way? Once you pre-curve your file, engage them in tentative apical split or middle split or coronal split, and then switch on your endomotor. Once you do that, you would go a little bit more apically with your file. Once you encounter any stop or a resistance, immediately stop. Don't push or give pressure to your rotary files, because they are already under a lot of stress. You cannot give any pressure. Just remove it, irrigate it so well. Take your small hand K files, 10 number file again into the split, and this is how step by step you can reach to the apical most area with your pre-curved rotary files. It becomes so easy. It is just a matter of believing and diagnosing. Then with the help of such nice files, we can just shape them within 2 minutes. So once I could see this, I would obturate. Now here the tip is, most of the people usually they ask is, after I get two splits here, it becomes so difficult to obturate both the splits, especially when they are in apical third. So I will be showing another case of mine where I would show how to obturate it. This is a case which clearly shows me that the premolar has it's bifurcating. It has a split in the apical area. So it might look easy, but ask me, this was one of the most difficult case. Why? Because in premolar we have very limited buccolingual dimension. I don't want to ruin the structure also. So even under magnification, I can see now that the chances of having a split is high. Only under magnification, I would take my pre-curved file, and then I would explore this canal lingually. I would just curve the file more lingually. I would take that, under magnification, and then only I would see this split, and you see the picture, the split was almost into the lingual wall of the dentine. So this is how you get these splits. And once you start shaping, if you are not using magnification, trust me, it is like a sometimes you will get it, sometimes you will miss it, you will go keep on going crazy of missing, getting. It is not predictable. But once you start seeing it under magnification, and you take your files, and the moment you are able to take your rotary files, that to your longer files, 25 files, pre-curved files, under magnification, you would have a clear vision of what you are doing, because longer file will give you a better vision. So you just pre-curve the rotary files, the martensitic files, which can be pre-curved, and then just enter into this split, which you can see. And once you enter, engage your file there till the resistance, press the motor, it will go further. And the moment you start catching it, it becomes so easy, a job of maybe 30 seconds or 1 minute. So the moment you get that split, it is easy. Now when you talk about obturation, in this case it is also not so easy, because the split is so apical, the dimension is buccolingual is so narrow. So how can I obturate it predictably? The best way I would prefer is, if I have prepared the canal, suppose a 2506 in both buccal and lingual splits, I would always obturate with a 4% taper gutta percha, never with a 6% gutta percha, because your taper of your gutta percha, you need to have a good tuck back, that is definitely there. But you can get a good tuck back with your 30 number O4 or 35 number O4 gutta percha. You will verify it on radiograph, and then once you get a good tuck back, just remove, or you take your warm vertical compaction device or heated plugger, you just remove the remaining gutta percha from the split, and then clean the sealer, and then see under magnification. Until or unless you don't see the rest of the canal which is unfilled, don't try to take your gutta percha now, because what will happen, you will keep on taking your gutta percha, the gutta percha will keep on bending and coming out. So it will just waste your time. First, fill one canal, take your rotary file, clean the other canal again a little bit, so that orifice is very clearly visible. Once you can see it, it is just a matter of few seconds to take another, master cone into this split. Once you take a sealer coated split into this, sear it off again, and then do the backfilling. So using a warm vertical compaction technique or continuous wave compaction technique is extremely helpful in these cases, because it is so difficult. I won't say impossible, but it is so difficult to manage these cases with just your these normal lateral compaction techniques. So this is how, once you can clearly see the split, now you will just backfill it with the devices. The another case which is very interesting, has different approaches. When you don't see fast break is there, and your files are not reaching to the working land, and you have apex locator, and then you see that something is missing here. What is there? It is not a calcification. What is missing? Then you would just take out your file, take your 10 number K file out, just pre-curve it in more buccal direction or lingual direction or palatal direction, and then take it. Once you pre-curve it, the file would go exactly into the splits. Once you clean these areas, sometimes, not all the times you would be able, because this is extremely apical split. I was lucky enough to clean this or shape this with the rotary files, but sometimes we cannot just shape them well. So what we can do is, you take your hand files, because your hand files are predictable files, you can always pre-curve them and take them. You take your main canal, you prepare with your rotary files, and in the lateral canal or the split canal, which is shorter, you take your first 10 number file, 15 number K file, and 20 number K file, which are pre-curved well, and just create a good glide path with 10 number K file, and then shape it with 15, 20. And once you are okay with it, you can either use two separate master cone, If you are not 1% able to use separate master cones in such cases because it is tough, I would always advise you to use, if suppose my last file here was 2502, that is 25 normal taper file, normal hand file, not rotary file in the split, I would take a 25 or 3004 GP in the main canal, and I would take a normal 2% gutta percha with bioceramic sealer in the split canal. It makes it so easy. Also, I have cases where even if I'm not able to take my gutta percha into this area, but I prepare it well. I invested a lot of time in irrigation because it was really a task to clean this split, and I knew I have to do it. So I will spend more of my time in ultrasonic agitation here. After good amount of ultrasonic agitation, if you do a good warm vertical compaction, your chances of filling the splits are extremely good, even if you are not using a separate gutta percha in the small split which is present most apically. So in especially cases like this, when you have very small split, that too very apical, just be sure that you keep maintaining the glide path, you keep cleaning it with your small 10 number file, 15, 20 number file. If you are able to take your pre-curved no taper gutta percha, the best. If you are not able to take it, do a lot of irrigation and leave it for warm vertical obturation technique. It will do its own work. Last, I would like to talk in very short is about managing calcified canals, which is again a big challenge. Why does it happen? Has a lot and lots of stories. Why does calcification start? Maybe because of trauma, maybe because of very old carious lesion which somehow became inactive, and now after over a period of years it's again got exacerbation, and now the tooth is symptomatic. So also when cases we have very large amalgam restoration with the base, so chances of, or especially in vital pulp therapy cases, treated cases, you would get pulp canal obliteration or calcified canals. But suppose you get a case where this patient comes to you now, he's a almost 80 plus patient and upper 7, and you have a missed distrobuccal canal clearly. Patient is symptomatic. So what can you do? You can just remove the crown. The most important thing I would like to add here is managing a calcified canal is first you should be knowing. So in such cases, the most important thing comes is CBCT. So in calcified canals, especially in difficult access, I'm not talking about all anteriors, because most of the cases of anterior calcification, you can easily negotiate them without even CBCT. But yes, there are certain cases where you need to have a good CBCT. In calcified cases, when the calcification is quite reaching till apical 1/3. So with CBCT, it becomes so easy because now you know where is your patent canal which was not treated, and now you exactly know the measurements between your outer surface of the tooth and the canal orifices, or mesiobuccal canal to distrobuccal canal orifices, and with the precise measurements you can see inside the chamber and then clean it. Once you get it, use always ultrasonic tips to find out these canals, because in calcified chamber, if you are using cutting burrs, it is a disaster. The perforation chances are really high. Like this case, the patient comes in terrible pain because of somebody started endodontic treatment. According to the patient, she did not have any much pain, only sensitivity was there. The tooth was not much carious. That is patient's history to me, I don't know, but patient told me the tooth was having mild caries, a lot of food lodgement was there, and she had sensitivity. That was the only issue when she went to the dentist. But if you see this case, she came back with acute pain. You see what was done. The major problem that was done here was not that the dentist perforated it. That's not the problem. The problem is they used wrong instrument or the cutting instrument in such calcified chamber when they were not really sure about the location. So the most important thing again come here in picture is, don't try to make your access more mesially. The canals are almost towards the center, and it is always wise to have a caries directed approach for access opening, because they will give you a straightforward path towards the pulp chamber, and then you can directly see a caries driven access. The caries was there, the access they made was a perforation, so it is, the entire tooth structure is gone. So in such patients, when they are geriatric patient, you have calcified chamber and canals, you need to be very, very precise in understanding what instrument are you using and where should you stop before making a blunder, before making a CBCT image. Or if you can get a CBCT image in the first instance itself, well and good, get it, because these are challenging cases and you need to be very precise. So the best way of managing a calcified canal is first to visualize. For that, magnification is most important, especially in calcified molars. Once you catch the canals, most important thing is to have a good glide path. You keep on using your stiff stainless small number files in watch winding motion till you reach, or till you try to reach to the apical area. What I would prefer, as per all other cases, I would prefer to make a, after I get the canal, the best and easiest way is to orifice enlargement. Once you enlarge your orifices, your irrigation would flow inside and it would lubricate rest of the canal apically. It becomes so easy to maintain a good glide path then after you have a good coronal enlargement. So after your good coronal enlargement, you keep on taking your 10 number K file under lubrication in a watch winding motion. So make sure that lubrication is always there, and please don't ever believe that your lubricant like your EDTA gel or something is going to open the calcification itself, because I keep hearing that we put EDTA for 2 days and we recall patient after putting EDTA gel inside that the canal will open. No, it is not going to open. The only thing that can open is you and your instrument. You yourself can open a calcified canal by a proper scouting procedure. No gel or something, they can just lubricate and give you a smoother pathway. That's it. So once you get a good glide path, then everything else is so easy. So after getting a good visualization, either you are not getting at a magnification, you get the CBCT done. Under magnification, you try to follow the instruction given by CBCT. Get the canal. Once you catch the canal, orifice enlargement. Once you enlarge the orifices, do a good amount of lubrication of the chamber and the canal itself, and then take a small 10 number K step file in watch winding motion till you reach to the apex. Another extreme cases when you cannot just do it manually, the latest things are guided shaping procedures. Just like we do our guided implant surgery, it is so easy. You take a CAD-CAM scan and then you take a CBCT scan, you just overlap them, you get a stent made, and with the stent you have in the stent you have a clear cut direction. Your file will engage inside. You would let them know that which file are you going to use, so the stent would just like a blind procedure for you. But again, it comes in picture according to me when you feel you cannot do it on yourself. But I feel having a CBCT and having a good magnification is in most of the cases is sufficient enough. So this is how I would like to conclude my presentation for today. And with this quote, that we don't grow when we are doing things which are easy. We are keep on doing routine things every day in and out. For past so many years, we are doing the same root canal procedures every day, morning, night. But if we don't encounter such challenging cases, we would never grow. So for our growth, it is really important to take these challenges positively, to understand why we are missing, what we are missing, how can we approach them better. Take the help of good literature and your mentors. And the real problem is not where the machines think. But the main problem is whether men think, because you see in past so many years we have so many technologies. And today's my presentation I showed you failure of magnification just because of my own mindset, failure of not getting a catching a canal, breaking an instrument, everything was there. It's not the instrument which is governing, it is thus the brain of operator. The knowledge and the skills, they come first, and then these technologies are there to back us up. So you cannot just rely on machines and always machines that they are going to do work for you. No, they will help you, but they are not there to work for you. So the most technologically efficient machine that man has ever invented is the book, is my um, best, or I would say major takeaway for all of you, that being into practice, sometimes we just keep on flowing with the flow. We have lots of patients since morning till night, we are super busy, and we are by the grace of god we are maybe earning good. But what happens is we just stop growing. We stop growing because we stop learning new things, we stop listening to people, we stop reading new things, we stop reading scientific evidence, what does it say. And that's where I feel that's where our economic growth may go, but our personal growth, it just stops. So that is my real big take home message for every student or a clinician who is listening, because I know most of the clinicians are listening to this presentation here, is please have a good backup of literature for what you are doing, why you are doing, and what can you do to improve your work. This is how I would like to end my presentation, is what if I fall? Oh, but my darling, what if you fly? So to be a good flyer, you should need to learn how to fall first. That is, I feel, is most important. To see your own failure is the best teaching one can get. I must have heard thousands of, I would say, I'm a good for endo, I can listen to many people if they are talking of some interesting things which are of my interest. But after listening to them, I would get inspired. I would certain areas of my brain will get activated to see things more effectively. But until or unless I perform them and replicate them in my work, or if I fail in my own work, if I see my 5-7 years back own procedures where I fail now, then I would learn things which no one can teach me, no book or no person can teach me. So our own failures are the best teachers, is what I really feel. So with this, I would like to end my presentation, and thank you so much for patient listening this afternoon on a busy day of clinic. So thank you one and all. Carol, over to you.
Hello, Dr. Shalu. Thank you for your excellent lecture.
Yes.
Now I will pick up some dentist question. Please answer them. The first question is this one. Hello, Dr. Shandu. Please see the screen. There is the first question is from Dr.
The question, okay. How did you locate MB2 when split is below CJ? What instruments did you use for troughing? Okay, it's a nice question. So how did you locate is, I obviously took help of both magnification and CBCT in that case, because under magnification, I could not see the split. So I had to take a CBCT to see where exactly my split was starting. So with CBCT, you get even the exact measurement, that from CEJ it is 2 millimeter, 3 millimeter, or 4 millimeter. And then you have a mindset, and under magnification, you would just pre-curve your, CBCT is like your entire navigator. So they will tell you that you have to go in mesiobuccal direction or mesiolingual direction, and then you will just pre-curve your file in that direction, and you would take from the same orifice, and just pre-curved file will fall into the right place. So I usually don't rough it much. I would just, obviously I will do orifice opening, but I don't believe in removing a lot of dentin structure there. It is just that after CBCT, using a pre-curved stiff 10 number K file is sufficient enough to reach or bypass that split. That's my.
Okay. Okay. The next one. Next question.
How to find calcified canal is like, I think I told enough in detail that to find a calcified canal, you really need to have magnification, and in some cases, or especially in molars, you need to have a CBCT image with you. Then only you can predictably and conservatively approach those cases. You can do those cases without CBCT also, but chances of dealing them conservatively are less. So if you want to do conservative without damaging healthy tooth structure of the patient, it is wise to use both a CBCT scan and good magnification for your calcified canals.
Okay. Friends, yours, please. The next question.
D finder or C plus? I usually use C plus, but both are fine. They both are fine. They are meant for these purposes, so they are okay. They are fine. You need to have just a stiff tip and a 10 number K file. That's it.
Okay. The next question.
From your experience, how often do you find middle mesial? So I would say, hi, doc. In my area, it is so common. So I see we have lots of as you know, we have lots of social media group, we have WhatsApp group. So what we see in even in one country, we have certain geographical locations where the chances of getting medial mesial canal are really high, and some people don't even get it much. So, but if you ask about my practice, I do get it frequently.
Okay. The next question.
How to shape C-shaped canal? I already explained well that you, for C-shaped canal, having a good magnification and idea where and how many canals you're preparing, the shape of the canal, the first and foremost thing is using an ultrasonic tip to trough that area, to clean the isthmus where lots of dead pulp tissue is lying. So after you do a good troughing, it becomes so easy, and shaping can be done with any rotary file. You just have to be a little less aggressive because chances of strip perforations are high, especially in lingual wall area of the root. So the shaping is same. It is just that you need to use magnification. You need to have a understanding of what shape of canal you are dealing with. The shaping will remain same, orifice opening and then crown down manner.
Okay. Here is the last question.
How will you proceed obturation of one divided into two canals, which we can't see under scope when split is below the curve? I already explained in detail that if you are talking about I'm not able to see my split in under magnification, it has to have a apical most split, because the case I showed you having a deep mesial split, I could see it well under magnification. So even under magnification, we can see apical third split also in most of the cases, but we cannot just shape them under magnification. So in such cases, you just have to have a pre-curve filing and maintaining the pre-curvature and following either the CBCT evidence or your if you catch it without CBCT, you just keep following the curvature or the pre-curvature that you made in your first C plus file. So you keep maintaining the same curvature and use the file in the same direction, maintaining, suppose you pre-curve it in buccal direction or lingual direction, take all the files in the same direction, use intermediate files, not with jump to the higher number of files, and keep on going into a watch winding motion. The first step is to catch that split. Once you catch that, split your file and then keep on doing watch winding motion. That is how you can do it. It is a skillful procedure, I would say, and everyone learns it with after performing a lot of similar cases. It's definitely not so easy, but yes, one can easily do it after having a good hang of it.
Many friends for Dr. Shalu, wonderful speech and answer the dentist question. Thanks for your time, Dr. Shalu.
Thank you so much. Thank
Okay.
you.
Now is our rotor time. Thank you, Dr. Shandu. You can have a rest now. Thank you so
Thank
much.
you. Thank you.
Now is our rotor time. I will pick up the one lucky person who win our lucky gift. Today our gift is Ultra Smart, and the dentist have seen the video during the Dr. Shanu presentation. Ultra Smart ultrasonic activity is very important when you're doing the endo treatment because it's for clean the root canal. So this is very big gift for this presentation. Now we pick up the lucky person who will be. Okay, let's try. Okay, we get the common. Total is 26. Now start. Who is the winner? The winner is Rochardon. Rochardon. So we will connect you. We will connect you after our webinar, and we will connect with our local dealer to provide a gift for you. Congratulations. COXO is continue to do the free public every week. As Dr. Shandu say, knowledge is very important for the dentist. So if you want to learn more technology and knowledge, please follow our page and continue to follow our COXO free public webinar. And if you want to buy any COXO product in Indian local market, please connect with our local dealer, Sarah Mango, and you can see the information, our located agent information in the comment. And the last step, we will give you the link. Now we will provide the link to applicant their certificate form. So please applicant the form within 5 hours and leave your correct message on them because it cannot modify. So see you next time. Bye bye.